Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 27th episode of Optometry series. I would like to thank my team members, Ms. Anshika ma'am and Ms. Meenakshi, for their continuous support towards the Optometry series. Thank you, both of you. Welcome. With reference to the age-related macular degeneration awareness month, so today the topic is about ARMD. So how to identify and what is the nutritional requirement for ARMD is today's title. I'm so happy to welcome our moderator, Mrs. Deepika ma'am. Thank you so much for joining with us today, ma'am. Yes. So now I request our MC, Ms. Manisha, to welcome the today's moderator and to share her profile as well.
Good evening, everyone. I am Manisha, currently pursuing my first year in optometry at Dr. Agarwal's Institute of Optometry. I'm delighted to introduce our moderator for today, Mrs. Deepika Kommanapalli. Ma'am graduated from the Boston Law School of Optometry in India in 2009, obtained her postgraduate degree at the University of Chicago. Today, she stands as a practicing optometrist with a special interest in retinal imaging and visual electrodiagnosis, enriching the lives of our patient through private practice in Bristol, United Kingdom. She is a beacon of inspiration, embodying the values of critical thinking, problem solving, and lifelong learning. As a mother of two, she exemplifies the delicate balance between professional excellence and personal fulfillment, proving that with the dedication and perseverance, anything is possible. When she is not immersed in the world of optometry, she prefers to learn new skills and to travel. Thank you so much for joining today's episode as moderator, ma'am. The speaker for today is Ms. Deepika, currently pursuing her M.Opter second year in optometry at Dr. Agarwal's Institute of Optometry. Ms. Deepika, please begin your presentation.
Starting from ARMD, it's the most common cause of blindness prevalence in developing countries, particularly in people older than 60 years. Macular degenerative changes involves the central part of retina, that is the fovea. The central vision is affected, resulting in difficulty in reading, driving, and etc. It accounts for about 8.7% of all types of blindness worldwide. Risk factors can be classified into socio-demographic, lifestyle, cardiovascular, hormonal, and reproductive, inflammatory, genetic, and ocular. Socio-demographic factors include age, gender, race, socio-economic status. Various studies have demonstrated an increase in prevalence as well as progression of ARMD with age. Starting with pathophysiology, wet ARMD, photoreceptor and RPE sends distant signals to choriocapillaries to make new vessels. Exact pathophysiology is unknown. New blood vessels grows behind the macula and are very fragile. Proliferation takes place, leading to scarring of the macula, potential for rapid and severe damage to the vision. Dry ARMD, insufficient oxygen and nutrition damage photoreceptor molecules. With age, the ability of RPE cells to digest the molecular decreases. So excessive accumulation of residual metabolic derivatives and highlight material seen, that is drusen. The RPE and other degenerative and atrophies seen in exact pathophysiology is unknown. Loss of central vision occurs. ARMD exact cause is unknown, but oxidative stress, particularly in the retina, is believed to contribute the pro-oxidative environment in human eye. The vulnerability is related to several factors such as the high vascularization, which result in high oxygen tension, the light-induced stress in fovea due to increased cellular density and metabolism, the retinal tissues that present high quality of unsaturated fatty acids and photosensitized compounds which are highly susceptible to oxidation. The exposure of the retina to cumulate radiations. Signs, drusens, geographical atrophy can be seen, subretinal fibrosis, RPE changes, subretinal fluid, hemorrhage, and hard x-rays. Symptoms of decreased visual acuity, insidious or sudden onset, blurred vision, distorted near vision, scotoma, visual distortion, metaphoria, and micropsia, vague visual complaints, which are a combination of all these. The major risk factor is old age, presence of AMD in other eye, family history of AMD, smoking and alcohol, hypertension, BMI of 30 kgs per meter or higher, diet low in omega-3 and 6, vitamin, carotenoids and minerals, diet high in fat, and lack of exercise. Basic on the early, intermediate, and advanced classification. Early ARMD has presence of number of small or intermediate drusen. Small drusens are frequently seen in those with 50 and older and can represent an epiphenomenon of aging. Intermediate ARMD, macular disease, characterized by either extensive drusen or small or intermediate size. Any drusen large size of greater than or equal to 125 microns. 124 micron is the average diameter of retinal vein at the optic disc margin. Advanced ARMD, presence of geographical atrophy with numerous drusen, choroidal neovascular membrane. These persist along with the sequelae such as subretinal or sub-RPE hemorrhages or serous fluid and subretinal fibrosis. Dry stage and wet stage. Dry stage can be categorized as most common, which is 80% of older population, drusen deposits seen in macula, thinning of the macular tissues, which is a geographical atrophy, develops slowly and less severe. Less common is 10 to 20%, progress from dry stage, abnormal blood vessels developed under the macula, bleeding of eye tissues developed rapidly and more severe. Based upon drusens, drusen bodies are extracellular deposits of lipids, proteins, and cellular derivatives which are found within the layers of retina and appears as small yellow deposits on the dilated eye exams. Specifically, drusens resides between the basal lamina of retinal pigment epithelium, that is RPE, and the inner layer of Bruch's membrane BM. Drusens are small, round, yellow lesions located along the basal surface of RPE, mostly in posterior equatorial of the retina. Based on size, small, intermediate, large, and drusen PED are classified. Then, based upon hard, soft, the drusens are classified into the following things. Hard drusens, discrete and well demarcated, mild and dry ARMD, small in size, they are homogeneous content. Soft drusens, amorphous and poorly demarcated, moderate, dry ARMD, large in size, and it is also homogeneous content. Confluent drusens, contagious drusens which has clear boundaries, which will look as like patches. Cuticular drusens, numerous small drusens are seen, dot-like yellow deposits. Subretinal drusenoid deposits, these are white dots or retinal appearance mainly located in the perifovea. Next is the change in RPE, which is a retinal pigment epithelium. The RPE is specifically known to undergo several structural changes, including loss of melanin granules, increase in number of residual bodies, accumulation of age pigment lipofuscin, accumulation of basal deposits on within Bruch's membranes, formation of drusens between the basal lamina of RPE and intercollagenous layer of BM, thickening of the BM, which is a Bruch's membrane, RPE, microvilli atrophy, disorganization of the basal infoldings. Next comes the geographical atrophy. Geographical atrophy occurs in stage of dry ARMD. GA is characterized by well circumferenced area of RPE atrophy, which allows visualization of the choroid. Geographical atrophy is not the correct term for this stage, as it includes RPE, choriocapillaries, and retinal atrophy, which is an interconnected and lead to irreversible atrophy. Geographical atrophy can occur either in a primary form of AMD or followed by secondary form after absorption of soft drusens, after flattering of RPE detachment, or a consequences of CND regression or rupture of RPE. GA of RPE is caused by severe loss of visual acuity in 20% of ARMD patients. This is a geographical atrophy in which the period is 6 months. First photograph was took under like 1 week, and next is 3 months, and next is the 6 months. In 6 months, we could see the geographical atrophy has been developed in a large size, also along with the dot hemorrhages. Next comes the wet ARMD. Wet ARMD occurs less, most common, but in fact more aggressive when compared with dry ARMD. Wet AMD results from the development of neovascularization or new blood vessel beneath the retina. These abnormal blood vessels may break into retinal cell layers. The leakage of fluid and proteins from these vessels causes scar formation throughout the macula, which ultimately result in deterioration of the central vision. The wet form of AMD is characterized by occurrence of RP detachment, choroidal neovascular membrane, CNV, subretinal hemorrhage in macula. The terminal stage will be the disciform scar. Coming to RPE detachment generally characterized by elevation of RPE layer from the Brooks membrane. This can be drusen RPE detachment, serous RPE detachment, hemorrhagic RPE detachment, and fibrovascular RPE detachment. Choroidal vascular membrane CNVM. CNV involves the growth of new blood vessels in the originate from the choroid through a break of Brooks membrane into subretinal pigment epithelium or subretinal space. This can be occult and classic. Occult when the neovascular membrane is located between RPE. Classic is the pass through RPE and locate above the RPE in subretinal spaces. Subretinal hemorrhages. A subretinal hemorrhage is accumulation of blood between the neurosensory retina and retinal pigment epithelium arising from the choroid or retinal circulations. Disciform scar. This is the last stage, like disciform scar develops from regression of subretinal hemorrhages and retinal edema and hyperplastic elements of the RPE. This is a simple case about ARMD. A patient with 67-year-old female came with a complaint of both eye, painless blurred and diminishing vision, distance and near with the glasses. She's using the glasses for almost 40 years and her current glasses is 2 years. She had no history of any trauma, general health or family health and allergic history. Her prescription, past prescription was this. Her visual acuity uncorrected was 636 and 5/60. Objective refraction showed the values, and with acceptance, she was able to read 6/12 and 6/12 partials, both eyes, and near vision of N8. Slit lamp examination showed normal along with mild changes in the lens, which is the cataract. Fundus examination showed drusens and the media was hazy because of the cataract. Pigmented changes was also seen. This was her fundus. We can see drusens, the media is hazy and mild RPE changes. OCT showed altered choriocapillary complexes, subfoveal fibrosis and PED changes along with the drusen. The final diagnosis was non-executive age-related macular degeneration, advanced atrophic with subfoveal involvement. The advice given to the patient was periodical arm's length home monitoring, chance from dry to wet, and need for retinal intervention. She was undergone cataract surgery. After that, the same prescription was given. Next one is the ARMD and nutritional supply. The right nutrition can optimize macular health. So an eye health diet is important in reducing the risk of age-related macular degeneration. It could also slow the progression of ARMD. Research says that food rich in vitamin C, E, zinc, lutein, xanthaman, and omega-3 fatty acids are linked to lower the risk of ARMD, cataract, and perhaps every dry eye later in the later life. Age-related eye disease studies. ARDS was performed in 2 decades. First study was performed in 1992 to 1998. This was conducted by National Eye Institute involving over 4,500 people tracking the development of ARMD. Study researchers tested whether taking nutritional supply could prevent or slow the disease. The second phase took place between 2006 to 2012 in the same National Eye Institute conducted by 5-year study involving 4,000 AMD patients to evaluate the effectiveness of adding omega-3 fatty acids or lutein xanthaman to the ARDS formula. The ARDS2 participants who took antioxidants minus beta carotene but with lutein and xanthaman had an incremental increase in benefit compared to those who took ARDS formula. Taking AREDS and AREDS2 supplements reduces the risk of progression from intermediate to advanced AMD about 25%, but does not prevent ARMD onset. Current and former smokers should not take ARDS S2 formula to avoid the ARDS formula with beta carotene, which increases risk of lung cancer. This is the formulation composition, which has vitamin C, vitamin E, beta carotene, copper, and lutein, xanthaman, and zinc. Vitamin C rich fruits includes oranges, grapefruits, kiwi, strawberries, tomatoes, and red green peppers and broccoli. Vitamin E has many things in almonds, sunflower seeds, olive oil, and avocados. Beta carotene is highly present in yellow, orange, and green leafy vegetables and fruits. Copper is mostly found in all seafoods. Examples: shellfish, seeds and nuts, organ meats, wheat, bran, cereals, whole grains products, and chocolates. Lutein and xanthamin, both or these are naturally present in the retina and pigment source like leafy greeny vegetables like kale, spinach, broccoli, asparagus, and colorful fruits and vegetables. Zinc is found abundant in legumes, beans, and lentils, seeds, meat, seafoods, dairy, and eggs. ATR's formula and ADR formula differs mildly. In first formula, we don't have the composition of lutein and xanthamin. Then it was formulated to eradicate beta carotene and add these two. Next comes the Mediterranean diet. The Mediterranean diet, influenced by vegetarian lifestyle, has been linked to reduce the heart disease AMD risk, with plant and seafood based options being particularly beneficial. Green leafy vegetables, tree nuts like almonds, cashews, and walnuts are used. Seafoods as your primary meat source. Healthy fats such as choose olive oil over your butter. Whole grain bread, cereals, and pasta. Lots of herbs and spice added to your food to lower your salt intake. Moderate amount of dairy, yogurt, and cheese and eggs. Those from the regions also enjoys a glass of red wine with their dinner, which has its own health benefits in moderation. So there is a truth of a toast to the salute. Carotenoid age-related disease. The high adherence showed that the high adherence of Mediterranean diet was associated with low prevalence of early ARMD. Next is the low glycemic index diet. People who are in risk of developing age-related macular degeneration can benefit by following low glycemic index. Diabetic can lead to severe health issues and vision loss and can be managed by avoiding a high GI foods and consuming low GI foods to avoid spikes. Oatmeal or muesli to sweeten breakfast cereals, brown rice over the white rice, whole grain breads over the white bread, drum wheat pasta or sweet potato over a baked potato, nuts and over potato chips. Calcium and AMD. Earlier studies suggest that calcium lower the risk of developing AMD, but newer studies is uncertain. Fish can lower ARMD risk. Studies found that women who ate fish high in omega-3 fatty acids at least twice a week were less likely to get age-related macular degenerations. Lifestyle changes to patients with AMD. This summarizes about increased consumption of green leafy vegetables and fatty fish at least twice a week is recommended for all AMD patients. A Mediterranean diet may be offered addition benefits and beyond AMD. Patients with moderate or advanced AMD should consider using ARDS-based supplements. Current and former smokers should avoid supplements containing beta carotene, which may increase a risk of lung cancer. Patients with uncertain about lutein intake should consider lutein with xanthan ADS based supplements, while those with normal or high lutein intake can be modified into beta carotene free ADS formulations. These dietary changes can delay the onset and slow the progression of AMD. ARDS based supplements can slow AMD progression but do not prevent its development. Adopting a Mediterranean diet, engaging in physical activities, avoiding smoking, and reducing sedentary behavior can lower the risk of early ARMD, decreasing the incidence of advanced AMD, and lessen the burden of treating the diseases. These are my references, and thank you.
Thank you, Deepika. It was a very clear explanation. Now I request our moderator, Deepika ma'am, to share her inputs.
Yeah, good presentation it is. You've included Mediterranean diet as well, which is a good thing. So one tip when you're looking, so when a patient comes to you, saying that there is drop in vision or there's family history of macular degeneration, is always do AMSLIS. Okay, if you see that the vision you see that there is drop in vision. And if you've already done just slit lamp examination, not fundus examination, but just anterior segment, always do AMSLIS as well. Yeah. And another thing is, so somebody asked in the chat there, how to differentiate between drusen and hard exudates? How do we do that? What segment? So where are hard exudates present and where are drusens present is a question. And how do you know where are they present? Just looking through your 90D or 70-80. How do you know?
Drusens mostly will be present in the near macular and foveal regions, ma'am, and it's very fine, and it's like it's fine compared to an hard exudate, whereas hard exudates it's like little bit patchy on the side, so that we can differentiate between a hard exudate and a drusen, ma'am.
Yeah.
So drusens are more fine.
Yes, you're right. Drusens are more fine, like especially hard exudates are more fine, and they are not necessarily present at the fovea or macula. They could be anywhere in the retina. So to begin with, I see a lot of patients where I see drusen somewhere in the periphery, because I live in the West here, and they have family history of macular degeneration. They routinely turn up for their routine eye examination, and I see drusens just anywhere. Like it could be in the periphery, it could be, you need to be careful. So they might not have these drusens right in the center when they come to you, but they could be in the periphery. Right then you can just immediately recommend them about their lifestyle changes, their dietary changes. You can put them on, you can recommend them ARIDS or ARIDS 2 formulation, but you need to make sure that they're definitely, they haven't smoked in the past or they're not smoking at the minute. So that's one thing that we need to definitely check before recommending. And I also see another question there. So somebody asked, how can we differentiate ARMD from Stargardt's? What is ARMD?
It's basically age-related changes in
Exactly. Stargardt's only happens in the first 2 decades of life, so it's early onset there. Yes, both of them have some similarities where you see this fatty material at the macula, but ARMD can also have drusens, as I said, not just at the macula, but also in the periphery. Whereas Stargardt's is very particular. It only happens, these changes that you see in Stargardt's only happens at the macula, nowhere else. And it is presented in the first 2 decades of life. And the presentation as well, if you look at OCTs and Stargardt's and ARMD, it's very different. So that's another way to look into it as well. Yeah. Any questions there? Anything?
We have a few questions from YouTube audience also. So I'll read out the questions for you, ma'am.
Yeah.
First question is ARMD and hereditary disease?
Hereditary disease. It's what, ARMD and?
Hereditary disease. Will it pass on to generations?
Sorry? I didn't get you.
Will it pass on after generations?
Will it be passed on to other generations? ARMD. Very much, very much. I see a lot of the cases. So where the parent has ARMD, more likely that the child will have it. Especially in today's generation where we're all like, we are all getting food from takeaways, Swiggy, Zomato. We are eating high fat food, sedentary lifestyle. If there was macular degeneration in the family, most likely, yes, it is passed on, and it will be much worse. If they smoke, it will be much worse because it's hereditary. So you already have one risk factor. because it's hereditary. And two, if you're eating high fat food, it's another factor adding up. Free smoking, another factor. So it's like it depends on how many factors you keep adding. So it's like if the person is white or Caucasian, another factor. So it's like so many factors the risk increases with each factor adding up. So that's how we have to look at it. But yeah, it can be hereditary very much. So if one parent has it 50% anyways, but if both parents have it, which happens in the West, so yeah, 100% likely.
Thank you so much, ma'am. I guess we answered the second question also. The second question was who are more prone to get AMD?
As
We
I
answered
said,
that question also. Yeah.
yeah, as I said, over 60, it's not necessarily Caucasians as such. It can also happen in Indians and Asians. If there could be risk factors like genetic factors as well involved there. But again, high fat food, red meat, long time ago when I was training, a consultant said red meat can also add up. Like over a certain age, what happens is your body cannot digest certain kinds of like fats. It could be dairy products, it could be red meat. So what happens is because of that as well, the metabolic waste just like they kind of like jam here and there. So that can also lead to problems like this. So it's just that when you see a patient, you need to when you're recommending diet, you need to tell them about, okay, you cannot have high fat food because that will worsen the situation, or that will speed up the increase in the number of bruisings and all of that. So, and also the reason, despite them changing the lifestyle and having antioxidant rich diet, that is what you recommend your patients. Antioxidant rich diet is nothing but, like you said, like Deepika said, it's white meat, brown, like unrefined. Sorry, what do you say? Like brown pasta or brown rice, nuts. These are the ones like fresh vegetables, not necessarily spinach and kale or broccoli, but also like fresh vegetables on the whole. I think that should help. However, you should also recommend supplements right from the beginning, because if you have to get the same amount of what you get in supplements, you need to eat like 20 broccolis. That's not possible, humanly possible. So you should just put them on. You should just recommend ARIDS 1 or ARIDS or ARIDS 2 based on, again, smoking history as well. So that's what we need to do. Home answers, always give away home answers. When a patient comes with AMD, suppose not all of us are going to like end up working in a hospital, right? We'll probably eventually like move to, our own practice, or you don't know. So in that case, always have AMSLers. Always do AMSLers when you have such doubt. Like do the pinhole vision. If the vision is not improving any further, it should improve in cataracts and other corneal scarring and all those cases, right? If it's not improving, meaning that it could be a macular problem. And always do AMSLers just to see how bad it is. And again, if it's just distortion, it could just be dry macular degeneration. But if you're seeing these blobs or, good chunk of area missing, it could be wet macular degeneration. So you need to be careful about it. So dry macular degeneration here in the UK, you can manage it by yourself as an optometrist, because there is nothing much they can do at the hospital by an ophthalmologist. But wet macular degeneration, you need to be very careful. So you need to just immediately refer the patient so that they get the injections on time. Yeah.
Yeah, ma'am. Thank you. The next question will be how to identify AMD in the early stages.
AMD drusen's. So drusen's are the giveaway. If you see even one or two drusen's, you're going to see the patient yearly anyways. So these patients should be seeing you every yearly, depending on how bad the drusen's are. They don't, and you give home AMSLers anyway. So you need to say, do the home ampoules. If you find any change, you need to come and let us know anyways. But if the drusen's are not in the center, not at the macula, do not bother patient too much. Just say that I see some changes in the back of the eye. Okay. Luckily or fortunately, they're not in the center where it could affect your vision as much, but I do see them in the periphery, like, at the back of the eye there. So all you have to tell is change. If you need to change your lifestyle, do some exercise. If you eat a lot of like fatty food, try to reduce that. And we will see you yearly anyways. That is how you reassure your patient. But also make sure that you don't worry them too much, because there are so many other things at that age, right? It's not just age-related macular degeneration that they would be worried about. They're prone to falls. They're prone to a lot of other things. The children will be kicking them out of the house because they're too much of a pain at that age. Like that happens really. There are all other things going on at the age of 60 and above. It's not, it's, they would be facing, a lot of other challenges. They are retired from work now. They have other health issues. So you need to be very careful about how you word your things rather than putting more burden. Don't burden them. That's what I would say. Just say, I see some changes at the back of the eye. I'll see you yearly anyways. However, it would be better if you change this so that that doesn't get worse or that doesn't affect your vision in the future as much. It could progress, but at least it will slow down the progression. So that's how you need to put it down.
Okay, ma'am. The next question is, how does dry AMD gets converted into wet AMD?
So dry AMD, so if you see the drusens are right below the RP, right? So what happens is these drusens, as you've seen, hard drusens, soft drusens, they kind of like, they kind of like increase in size and they break the barrier there, RPCC complex. So they break the barrier there. So when the foundation is broken, what happens? Anything can enter, right? So the foundation is broken and the blood vessels beneath can leak into the subretinal space. And that's how dry AMD becomes wet AMD. So it's like there are bricks there, but then something happened, like there was a hole in the between the gaps, and anything. So suppose there is water underneath, it just leaks into the house. So that's how it is. That's how dry AMD can become wet AMD, because the barrier is no longer as strong and it's breached. Yeah, I hope the explanation helps.
Yeah, definitely. The next question is, what complications can occur if AMD is left untreated?
What kind of AMD? Because as I said, there is no dry AMD is not as bad as wet AMD, right? So wet AMD, if you leave it like that, what exactly happens in wet AMD is you have this VEGFs, right? So they are vascular endothelial growth factor. It leads to this unnecessary neovascularization, and these, as you know, the blood vessels are composed of 3 layers, like the inside. That is, normal natural blood vessels are very strong. So even the rush of blood can like stop it. Whereas the new blood vessels, they are not meant for circulation. So the structure itself is very fragile. So what happens is when there is and these are extensions of these normal blood vessels, right? So what happens is they leak really easily. A rush of blood, it breaks. And because of that, the fluid enters the retina, subretinal space there. So what will happen is the VEGF will keep, so it kind of like keeps producing these neovascular vessels, and they'll keep locking. So they'll keep leaking, and then the fluid is constantly accumulating. It will damage the tissue. It will damage your photoreceptors. It will damage everything. So obviously, once the tissue is damaged, there is no way, and it's continuously being damaged, the vision is going to drop. So the minute you see fluid in that will be seen on OCTs. So suppose you have access to OCT, always, even in dry macular degeneration cases, always look for that small, even if there is a small pocket of fluid, don't ignore that. Like that person needs an injection so that it doesn't get worse. So you should always look for the pocket there. And if that fluid is not treated, yes, there will be further drop in vision and there is nothing you can do. The longer the fluid is in there, the more damage it is going to do to the retina there. So you need to just be careful about that. I hope I answered the question there.
Yeah, ma'am. Thank you so much. The last question will be, what will be the low vision management for AMD?
Low vision management, that's not my strong pursuit anyways. Low vision management, firstly, to be honest, for any patient with, as I said, at that age, they would be, it impacts a lot of things. Like people who drive, they cannot drive anymore, right? Their license will be taken away. It's taking away their independence because they have to go shopping. They do things on their own, and at that age they don't get much help from their family also, like as I said before. So it's everywhere, it's across the globe that that at that like 60 and above, usually here what I see is I don't see them see macular degeneration cases at the age of 60, but I see them mostly at the age of like 70 and above, 70 and 80 and above. So at that age, everything is falling apart, as my patients put it. So my patients always tell me, post 60, everything falls apart, so enjoy your life now. So at that time what happens is, because there so many things are falling apart there, and it would have an effect there. You need to reassure your patient first that, look, I know this is going to happen and this has happened now. We can do nothing about it. We can preserve your vision by you going to the hospital with your injections. Even if they have little vision left, it will still help them with maneuvering around. First thing is, sometimes it's your words. It's all about how you put things across. It's like, we are here to help you. So it's like, do you have any support system back home or where you live? So things like that, you need to check that first. And then low vision management is what you would be looking at, really. That's what I would say. Then you can say that, okay, what do you need to first check what their lifestyle is. Do they read a lot or do they not read a lot? What do they need the help with? And then depending on what that is, you will help them with either magnifiers or whatever really helps them. Good lighting is always what you need to recommend your patients. Always. Good writing. And most of them also have like essential tremors at that age. So just check. Do you read a lot? If so, then you know what magnifiers you have to give depending on what their level of visual acuity is. But also like contrast and increase their contrast. So always say that, do you need a stand? If so, invest in a stand. Get a reading lamp, things like that. That always helps. And
Thank you
also,
so much, ma'am. Yeah.
And also, I think going forward, because everybody uses computers, will all have all sorts of other options to low vision management wise. So don't worry about it. Yeah.
Thank you so much, ma'am. I guess we have completed all the questions from Q&A, be it Zoom or YouTube. Anchi, ma'am, you have any questions to ask for, ma'am?
No, I think we had a very detailed discussion today, and it was very nice. Thank you so much, Deepika, for both the Deepikas for giving so much of time. The presenter, Deepika, it was a very nice presentation. Moderator, Deepika, thank you so much for all the inputs. I would just maybe summarize by saying the important points which our moderator has shared with us, that home AMSLR really plays a major role when we are actually seeing a patient. So there are certain times we do workups only at the clinic and we just leave the patient. So we should not forget about how wonders and home AMSLR can do, and about understanding what is the need of the patient. And once we know how the disease progresses, about the entire physiology of how does the ARMD proceed, we know what steps have to be taken. But using our words wisely when we are talking to a patient who's at that age would really make them much more comfortable and accept the situation rather than scare them at that age that they're going to lose their vision. So thank you so much, Deepika, for providing us with wonderful inputs. And I hope that the students would have really learned a lot today. So over
I
to you,
hope so
Govind.
too.
So thank you so much, Anshi ma'am. And once again, thank you so much, Deepika ma'am, for joining with us today. We would like to host you on another wonderful platform as well. So I would like to thank Anshi ma'am and Meenakshi once again for their continuous support towards Optometry series. And dear audiences, on behalf of Dr. Agarwal's Institute of Optometry, we wish all the students who's taking up their board exams all the very best. And with that news, I would also like to add that the admissions are open for the bachelor's in optometry at Dr. Agarwal's Institute of Optometry. I'll provide the link and the contact numbers in the description box. Please check it out. If you like this video, give a thumbs up and share it with your friends. If you have any doubts, please post your questions in the comment box. We will get back to you with all the answers. To know about more happenings at Dr. Agarwal's Institute of Optometry, do follow our Instagram, Facebook, and LinkedIn pages. The links will also be given in the description box. Meet you all in the next episode. Thank you so much.
Bye.
Bye, ma'am. Bye, everyone.